Hi, I'm Susan Ball from the University of Alabama at Birmingham. I'm delighted to share some results and some upcoming research that's ongoing about arlocabtagene autoleucel or Arlo-Cel. So arlocabtagene autoleucel is an autologous CAR T cell that's targeting GPRC5D. GPRC5D is a rational and promising therapeutic target for multiple myeloma because of its expression on the myeloma plasma cells with limited expression outside, mostly affecting the skin, nails, and the oral cavity. And so those are predominantly where the side effect profile comes from. It's already shown to be a very promising target. We already have talquetamab or Talvi, which is an FDA-approved medication, which also goes after the same target. So Arlo-Cel is a CAR T cell that's going after GPRC5D. So overall, in different meetings so far, we've shared results from the phase 1 study, which shows that in very heavily pretreated patients, those with 3 or more prior lines of therapy, we've already seen very impressive response rates over 87%, with a complete response rate that's upward of 50%. Median progression-free survival looks about 18 months, and the median overall survival is not yet reached, with a 1-year survival of 90%, which is very encouraging, particularly because almost half of the patients had received prior BCMA therapy. So this is sort of a new frontier for myeloma treatments currently. So right now, there are several ongoing studies that are evaluating Arlo-Cel in patients with relapsed and refractory multiple myeloma. One of them is the phase 2 quintessential study that is looking at patients with 3 or more prior lines of therapy in quadruple class exposed multiple myeloma. We have the quintessential 2, which is a phase 3 study of Arlo-Cel versus standard of care in patients with earlier relapse, so those who've had 1 to 3 prior lines of therapy. And then we also have the phase 1 study that we're presenting at ASH 2025. It's a trial in progress, so we do not have the results yet, but it is an ongoing study that's looking at Arlo-Cel, followed by maintenance with mezigdomide. Mezigdomide is a novel CELMoD agent that has immunomodulatory properties, and the premise is that it can help potentiate the effects of Arlo-Cel and hopefully result in a longer duration of response, longer progression-free survival, and hopefully improve patient outcomes. So we're excited about this study. It's currently enrolling as a phase 1 study. Of course, we're looking at safety of this combination. As you know, in CAR T cells, after treatment, we look at low blood counts, etc. These immunomodulatory agents can also cause low blood counts, so we're looking at safety as the predominant area of interest and the primary objective and endpoint of the study. We're also looking to establish the phase 2 dose that's going to move forward and be studied in a larger number of patients. And then, of course, we're always interested in learning about other toxicity profiles such as cytokine release syndrome, ICANS, and more importantly, non-ICANS neurotoxicity that could be seen with this agent, and then look at response and how response is modulated by addition of this therapy. In terms of what are some of the similarities and differences between arlocabtagene autoleucel or Arlo-Cel and talquetamab, there is, of course, some, like I say, on-target off-tumor toxicities that are common across the GPRC5D targeting treatments. So these include effects such as taste loss or dysgeusia, change in taste, or weight loss. We also have, nail disorders, rashes, skin toxicity. Now, these are seen significantly higher rates in patients who receive talquetamab, very likely because it's an ongoing therapy. As a one-time treatment, CAR T cell, by definition, is given once, and then, the effects sort of subside. So we're seeing a lot less of these toxicities. Less than a quarter of our patients to a third have had any. And most of these are not very severe, and they seem to improve without any intervention over a period of time. So they're transient, and they're self-resolving in the vast majority of cases, and they're not quite as intense. We don't see as many grade 3 or higher events. So it appears that the on-target off-tumor toxicity profile of Arlo-Cel is a bit better. However, we have seen a signal of non-ICANS neurotoxicity, which is a syndrome of unsteadiness, balance disorders, ataxia, and dysarthria or trouble speaking that can be seen in a small number of patients, about 10% in the phase 1 program. And this is something that we're trying to understand better. This has also been reported with talquetamab at a lower frequency. And so, balancing these on-tumor, off-target toxicities is going to be key in understanding which is right for which patient. We have not seen any Parkinsonism. We have not seen any cranial nerve palsies. We have not seen any Guillain-Barré. So those are the different delayed neurotox we've seen with BCMA targeting CAR Ts. We haven't seen any of those here, but we've seen this other non-ICANS neurotoxicity that I think needs better understanding.
If our videos have helped you in any way, and you're able to, please consider making a donation to help us continue this important work.
Your gift will go 3 times as far when we reach $500,000 by the end of the year.
Every contribution, big or small, makes a difference, and we're deeply grateful for your support.